but also for the lung. It's the most important risk factor for chronic obstructive pulmonary disease, or COPD. COPD causes it causes over 3 million deaths per year worldwide. It also is the most important cause of lung cancer. Now, all cancers represent about the second most common cause of death in the U.S. Lung cancer accounts for most of all cancers, and it has been associated with over 1.5 billion deaths per year. So that's tobacco. Now, if we examine the smoke contents of marijuana in relation to those of tobacco, what we find is something that probably would not surprise you, is that the contents are fairly similar, both qualitatively and quantitatively, if you look at the volatile phase constituents. Many of these, this is a very small portion of the thousands of components within the smoke. A number of them are toxic to respiratory tissue, particularly aldehydes and acrolein. They're also carcinogenic or procarcinogenic nitrosamines in both substances. If we then look at the ingredients within the particulate or tar phase of the smoke of marijuana compared to that of tobacco, we also find many of the same constituents that at least qualitatively similar. It may not be found in the same quantity, with the major exception that tobacco contains nicotine and marijuana contains over 100 cannabinoids, as you heard, not found in tobacco. Importantly, very important components within the tar phase that may lead to lung cancer are the polycyclic aromatic hydrocarbons. Benzpyrene is probably the most important human carcinogen and is found, at least in this study, and also it's been replicated by subsequent analytic chemists, a higher concentration in the smoke from marijuana compared to the smoke from tobacco. So naturally, this leads to the question, well, since the smoke contents are similar, although marijuana is generally smoked in smaller amounts than tobacco on a regular basis, but still, when marijuana is regularly smoked, does it increase the risk of COPD and lung cancer? Or these risks may not be as prominent as those found with tobacco, but do they exist at all? Are there any increased risks for COPD and lung cancer from smoking marijuana regularly, particularly if you smoke large numbers of cigarettes or joints a day, I guess, or blunts? And the other thing is that most marijuana smokers also smoke tobacco. Is that still true? Most marijuana smokers also smoke tobacco. They're dual smokers. So that the other question is, well, does marijuana, when smoked along with tobacco, increase the risk of tobacco? Is there a potentiating effect on the health consequences of tobacco? So we'll look at some of the evidence that addresses these questions. First, what is the association of marijuana when smoked alone or with tobacco, compared to tobacco alone or not smoking anything, with symptoms, or very common symptoms of COPD? Increased cough and sputum, in other words, symptoms of chronic bronchitis, wheeze, and shortness of breath. Shortness of breath is the most disabling symptom and the cardinal symptom of COPD. So about 30 years ago to the year 1987, we published a paper based upon actually a study in a convenience sample of over 400 smokers of marijuana alone, tobacco alone, the marijuana plus tobacco, non-smokers. And we administered a validated respiratory questionnaire and found that a significantly higher proportion of marijuana-only smokers in the light blue, the teal blue, I guess that is, compared to the non-smokers in the light blue, had increased cough, and sputum. Now, this is not just any cough or sputum. This is cough on most days for a few months out of the year, at least for 2 or more years. So that's how we define chronic bronchitis. Cough and sputum for over those periods of time. And they also had an increased incidence of acute chest illnesses compared to the non-smokers. It did not appear to be much difference between the marijuana-only smokers and the tobacco-only smokers, and there did not appear to be any additive effects of the two substances when smoked together. So that's our study. I think it was the first study of this type, but there were, over the same year, a study from the Tucson Epidemiologic Group was published. If you look, so there have only been a handful of studies that have examined this question about the association with symptoms of lung disease, and 5 of the 6 studies actually were in agreement, an association with increased symptoms of chronic bronchitis, but no increased shortness of breath, which is the most important symptom of COPD. There's one study, Canadian study, with divergent results. It failed to find, it examined an older group of smokers over the age of 40, and did not find any increase in symptoms of chronic bronchitis among these older self-reported marijuana smokers, but there did appear to be an interaction with tobacco smoking. So if they smoked both marijuana and tobacco, then there was an increased prevalence of symptoms of chronic bronchitis more than could be attributed to tobacco alone. It's the only study that I'm aware of that showed this interaction. Now, so we were interested in determining what the underlying pathology, lung pathology, might be that would explain or at least correlate with these symptoms, the increased symptoms of cough and sputum. And so Mike Roth, the previous speaker, actually performed video bronchoscopy on 10 smokers of marijuana alone, 10 of tobacco alone, 10 of the combination of marijuana and tobacco, and 10 non-smokers. These were the results. So what we're seeing here now is the bronchoscope is inserted into the lung, and we're looking at segmental or subsegmental, I guess, or segmental bronchi. You know, the tracheobronchial tree divides about 23 times. And with the bronchoscope, you can only see the larger airways down to about the 5th generation or so. This is the division between 2 adjacent bronchi. It's very sharp here. It's a pale mucosa in the non-smokers. Occasionally you'll see some redness, probably due to a reflex vasodilation from the trauma of the bronchoscope. What about the marijuana smokers? I think even to someone who's not experienced in looking at images like this, it's quite obvious that there is an increased swelling and redness in the marijuana smokers. In fact, some of the airways, the segmental airways, are nearly completely closed off because of the swelling. And very similar findings were found in the tobacco-only smokers. And here we see some increased secretions plugging one of the segmental bronchi. Now, when biopsies are done, and these were done in over 200 smokers of one or the other substances or both, so we do see rather striking changes. There were widespread histopathologic abnormalities in the smokers of marijuana alone. So here is the non-smoker, very nice ciliated epithelial cells. Here in the marijuana smokers, the majority of them, over 2/3 of them, had an increased number of mucus-secreting surface epithelial cells called goblet cells that secrete excess mucus, or an increased number of these are basal cells replacing the ciliated epithelial cells. And here we see an appearance that's very worrisome. It's squamous metaplasia, complete disorganization of the epithelium, which is a precursor of the development of lung cancer. 33% of the marijuana smokers actually exhibited this appearance compared to only 6% of the non-smokers. In fact, if you looked at the actual data, you'll see that these abnormalities were as common in the marijuana smokers as in the tobacco smokers, maybe a little bit more common in the combined smokers of the two substances. So it's obvious then that why should the smokers of marijuana have symptoms of chronic bronchitis? Well, we've destroyed their cilia, a lot of the ciliate epithelial cells. They have increased mucus production because they have an increased number of these mucus-secreting cells, and so have a diminished capacity to cleanse the lung of this excess mucus. You rely on the action of the cilia to get rid of the mucus. The mucus just hangs around, leaving cough as the only alternative mechanism to clear the lung of the excess mucus. So now, chronic bronchitis is not equated with COPD. It is true that most patients with COPD do have symptoms of chronic bronchitis, but there are patients with chronic bronchitis don't have to have COPD. So COPD is defined by lung function studies. It's a disease of persistent airflow obstruction, which is measured by a procedure known as spirometry. So patients take a deep breath in, they blow out as hard and as fast as they can, and completely as they can, and we measure the maximum amount of air they can blow out in 1 second. It's called the forced expired volume in 1 second. And the most accepted metric of airflow obstruction these days is the ratio of the FEV1 to the total amount of air you can expel from the lungs, from the top of your lungs, which is the vital capacity, the FEV1 FEC ratio, which in this case it's 60%, and normally it's greater than 70%. So what about the marijuana smokers? So we performed on these 400 or so smokers of marijuana and or tobacco and or non-smokers, all the tests that were commonly used in the 1980s for I think all the tests that have ever been described to measure the function of the lungs. We can divide them into measures of large airways, large and small airways, small airways. I realize the small airways are airways that begin with about the 7th division of the tracheobronchial tree, and the major site of pathology in COPD is in the smaller airways. Well, the bottom line is that all of the tests were normal, with the single exception of airway resistance, which you can't measure by spirometry. You need a special technique called body plethysmography. It was increased significantly by only 25%, which is probably not a clinically significant increase. So that's our study. And now, combing through the literature, you won't find that many studies. Less than a dozen studies have systematically examined the association between marijuana use and lung function in a population of smokers of marijuana and or tobacco or non-smokers. And actually, if you look at the FEV1 FEC ratio, which is a measure, the preferred measure of airflow obstruction, you do see a few of these 11 studies that show a reduction in this ratio. However, there's also an increase in the vital capacity, the maximum amount of air that you can blow out of the lung. So if you increase the vital capacity, you're increasing the diameter, which will lower the ratio, perhaps curiously. Well, actually, there is a tendency for marijuana smokers to take deep breaths when they smoke. I think that's the typical way that they smoke, deep breaths. They hold their breath for much longer than tobacco smokers, maybe 16 seconds as opposed to 3 seconds. And they sometimes even do a Valsalva maneuver, maybe to pressurize the gas to augment the absorption of the THC into the bloodstream. And this is a recipe that actually is likely to lead to expand the lung, as this occurs in swimmers. You know, swimmers, when they go their heads underwater, they're not breathing. When they come up, they have to take a deep breath, and then they put their head underwater again. They have increased vital capacity measurements. So I think a similar situation is actually manifesting itself in the marijuana smokers. But the FEV1 itself, if you go look down the list here, is not affected. I think there was one study in which it was inconsistently reduced, another it was actually increased. The only abnormality that stands out in the 4 cases in which it was measured was the airway resistance. The specific conductance is the reciprocal of airway resistance, and it was down a little bit. And I think the reason it was down is that there is evidence of inflammation and injury that Mike Roth found with his video bronchoscopy in the larger airways, largely including some of these larger airways are probably increasing resistance to airflow, and airway resistance is a measure of large airway resistance primarily. Okay, emphysema. So about half the patients with COPD do have significant emphysema. Now the diffusing capacity, which we had shown before but I didn't highlight it, is a very sensitive but non-specific indicator of emphysema. It was normal, and all the studies of diffusing capacity have been normal in marijuana smokers. But the most sensitive and specific measure for detecting emphysema and quantitating it is the CT scan. And the way you measure it is to actually you measure lung density. Actually, the computer does it. And if there's a lot of air in the lung because the air spaces are pathologically enlarged, which is how we define emphysema, then you should have a very low lung density below a certain threshold, 960 household units, which is highlighted here in red. So here the red areas represent emphysema. Well, the only study that I'm aware of that has systematically performed HRCTs in marijuana smokers was investigators from New Zealand, and they found no evidence of macroscopic emphysema in the marijuana smokers compared to the tobacco smokers or the combined smokers of marijuana or tobacco. Now, COPD is a progressive disease. Every year, patients with COPD lose an excessive amount of lung function. Eventually, they lose enough lung function to become symptomatic. So this is represented here by this trajectory of excessive rate of loss of lung function with age. So what about marijuana smokers? There have been only a few longitudinal studies of lung function marijuana smokers. We do need more. And so we did a longitudinal study. We remeasured spirometry over 8 years in our cohort of smokers of marijuana or non-smokers or with tobacco, etc. And we did not find any increase in the trajectory of FEV1. It tends to go down as you grow older. You lose about 20 or 30 ml a year, but it didn't go down excessively compared to tobacco smokers who did exhibit an excessive loss of lung function over time. In fact, interestingly, the smokers of both marijuana and tobacco had a normal rate of decline, suggesting either the marijuana is protective or possibly because the marijuana dual smokers didn't smoke as much tobacco because they were smoking marijuana along with it. Now, so when we looked at dose response, I don't have this slide, but if you look at the dose response with tobacco, the more tobacco you smoke, the greater the rate of decline. Look at marijuana. No marijuana, this rate of decline. 1.5 joints a day, this rate of decline. 3 joints a day, this rate of decline. This is for an average of 15 years. So no dose response was evident in the marijuana smokers. So and this is similar findings, I don't want to, because of time constraints, belabor this, were found by another investigator, again from New Zealand. So we would conclude then that while regular smoking of marijuana is associated with increased risk of chronic bronchitis and also associated with evidence of inflammation and injury involving the larger airways, the lung function findings at least don't support the concept that regular marijuana smoking increases the risk of COPD, at least at the population level. So let's finally look at the other major lung consequence of tobacco smoking is lung cancer and head and neck cancer. Is marijuana a risk factor for respiratory cancer? Well, we would expect that it might be. There is some evidence that would suggest a link. Remember the increased amount or concentration of polycyclic aromatic hydrocarbons, carcinogenic in marijuana compared to tobacco smoke. When we looked at the histopathology in the marijuana smokers, we saw a lot of squamous metaplasia, which is along with other histopathologic changes, are precursors of the development of lung cancer later in life. So that's one piece of evidence. We took biopsies from different areas of the lower respiratory tract, and we did immunohistology on these biopsies, looking for the proteins of some of the genes known to be involved in carcinogenesis. And one of these was epidermal growth factor receptor, and another is Ki67, a nuclear proliferation factor involved in cell growth. And what did we find? Marked overexpression of these two proteins, Ki67 and EGFR, we call oncoproteins, in the marijuana smokers, compared not only to the non-smokers, but even compared to the tobacco smokers, with a suggestion of some additivity. Also, more recently, other oncoproteins are found to be overexpressed in marijuana smokers. These were obtained from laryngeal biopsies from patients with laryngeal cancer. These overexpressed in the marijuana smokers compared to the other groups. Also, there have been several studies that actually back in the 1990s, I don't know whether there have been follow-up studies later on, suggesting that head and neck cancer and also lung cancer is more common when it occurs in young people. It's very uncommon to see these cancers in young people. But when it does occur in young people, it seems to preferentially occur in people with a history of marijuana smoking in a higher concentration than is found in the general population. And then there's some older epidemiologic studies that were positive, showed increased association. Well, these high relative risks, like 8-fold increased risk, these are occurred in people who are smoking tobacco along with the marijuana. It should never have been accepted for publication. You can't disentangle the effects of tobacco from marijuana if you're smoking a kiff. And this other study, where I was unfortunately a co-author, was flawed because it had an improper control, blood donors for the cancer victims. There's a lot of evidence against the link. Anti-tumoral effects have been found. There are a number of animal studies and cell culture studies that show a suppressive effect of THC on tumor growth. Part of that might be due to the toxicity of the THC given either in vitro or in the animals, as Dr. Roth has already pointed out. Now, the older epidemiologic studies, other older epidemiologic studies that were well performed, failed to show an increased risk. This is a cohort study from Northern California. These are three case control studies, no increased risk. So because of the conflict, we performed our own case control study, and we were able to obtain, for using the tumor registry, identify over 600 lung cancer cases in LA County, 600 head and neck cancers, and 1,000 controls. And you could argue, well, if you don't have enough heavy smokers, maybe you're underpowered to show an effect from the heavier smoke. If you don't see it with light smoking, you can't be sure you won't see it with heavy smokers. We had a number of heavy smokers. What did we find? Looking at the odds ratio, adjusting for all the usual confounders, at least the known confounders, no increased risk. In fact, if anything, a slightly reduced risk for developing, not significantly so, lung cancer in association with marijuana. When we looked at tobacco, 20-fold increase in the risk of developing ice-dose response lung cancer for those who smoke more than 2 packs a day. So there was another study, well, because of the time constraints, that showed divergent results from ours using exactly the same methodology. It also found an increased risk with increasing tobacco use. They found no increased risk looking at all smokers of marijuana, but when they broke it down into tertiles of marijuana smoking amount, they found an increased risk in the highest tertile. And they concluded that heavy marijuana smoking is associated with increased risk of lung cancer. But look at this, they had only 4 controls. You cannot derive valid estimates based on such a small number of controls. So I'm sure, obviously their estimates were imprecise and they're probably wildly inflated. And then, so if you look at, there have only been about a handful, 6 case control studies, all but that one study, that outlier from New Zealand, showed no increased risk or even maybe a slight suggestion of a decreased risk. And then there was another study, again, we're nearly out of time. So I have to sort of cut me off, but I also have 1 or 2 more slides. So it's a Swedish study. It's received a lot of press, but it's a problem. The bottom line is there was an increased risk if you smoked more than 50 times in your life, if you smoked marijuana before you were conscripted into the military in Sweden 40 years ago. And then they were followed for 40 more years, and lo and behold, those who had smoked more than 50 joints in the before they were conscripted had a higher rate of lung cancer death later in life. But they did not adjust for, they didn't even track marijuana use or tobacco use after they were conscripted. So obviously that's a flawed study. The likelihood is that they stopped smoking marijuana later in life, as it usually happens, continued to smoke tobacco, which is a more addictive substance, and that was the cause of their increase. So that's a critique. So a summary, so despite the presence of carcinogens in marijuana smoke, in concentrations comparable to those found in tobacco smoke, most of the evidence argues against the concept that regular smoking marijuana is a risk factor for developing respiratory cancer. I just want to say one thing. This is the last slide. So I didn't have, because I knew I wouldn't have enough time, the other potential risk that's not been adequately explored is an increased risk of pneumonia. So Dr. Roth elegantly presented some data showing some impairment in the activity of alveolar macrophages harvested from the lungs of marijuana smokers. They're impaired in their ability to kill bacteria and also kill fungi. That raises the risk. So their host defense is impaired, and these are real people. These are people who are smoking marijuana regularly. This is a real life study. So it's conceivable that could put them at increased risk of pneumonia. Some older, very old epidemiologic studies, a couple that suggested that there might be an increased risk of pneumonia. We do need more studies along these lines. I want to thank you for your attention.